to be able to interview one of our authors in this brief spotlight from our February issue of the Green Journal. If you could please just introduce yourself and say a little bit about your practice.
Hi, everybody. It's nice to be here. I'm Cecile Ferrando. I'm a urogynecologist. I currently work at Cleveland Clinic. I did my fellowship here 12 years ago and have been in practice for the last 9 years. Soon transitioning over to an academic practice at University of California, San Diego. So that's where I'll be as of late spring of 2024. I founded our Center for Transgender Surgery and Medicine. So we call it our Transgender Surgery and Medicine program here at Cleveland Clinic. It's housed out of our LGBTQ plus center. We founded it in 2016 and immediately started offering medical gender affirming care as well as surgical care. And for the last 5 years, I've been building our surgical service line. So in my practice, I spend half my time as a urogynecologist, but the other half performing gender affirming surgery, mostly genital reconstruction for trans feminine patients.
Thank you so much. Your article that you contributed for the February issue of the Green Journal is such a lovely and thorough overview of your expertise regarding care for gender diverse patients. How did you get involved in the care of transgender and gender diverse patients?
It's a long story. There's a lot of history. I am one of few individuals sort of in this cohort that's now taking care of gender affirming or doing gender affirming care, taking care of transgender and gender diverse people who knew very early on. So I actually went to medical school. I had a lot of postgraduate experiences after college where I was able to actually meet transgender adolescents and youth in my in-between time before going to medical school. I had this kind of exposure. It was a time where we weren't really talking about, certainly not about transgender health, but we weren't even talking about transgender people. It wasn't very mainstream and there was very little social media, but it wasn't mainstream in pop culture. And so I had these very unique experiences as a very young person myself before starting my medical career. And so I went to medical school and then to residency very focused, knowing that I would care for this population. The surgical aspect evolved over time as I discovered sort of my other loves and focus within OBGYN.
So if you don't mind to talk a little bit more about the training, let's say, somebody in our listening audience is a trainee or a medical student or somebody looking to a future in medicine, and whether they want to participate in the medical aspects of gender affirming care or the surgical or both, what are some of the avenues you might recommend somebody pursue if that's what they wanted their career to include?
We've come such a long way. So now it's so much easier. We're doing so much more of this care. It is much more mainstream and part of certainly academic centers. So it really depends upon what trainees are interested in. So there's a lot of opportunity to explore within the mental health sector and find mentors who are providing mental health care. Certainly in the medical aspect, family medicine practitioners, internal medicine practitioners, OBGYNs are doing gender affirming care. And then within surgery, there's really a few avenues, for surgery. Gynecology, it still remains probably one of the most narrow avenues. There is postgraduate training for individuals in GYN, and I'm referring mostly to reconstructive surgery. Certainly doing gender affirming hysterectomy falls under the purview of being an OBGYN, but GYN itself for reconstructive surgery remains an avenue. It's just more narrow. The other more common ones are urology and plastic surgery, where this type of reconstructive surgery has also become much more common within those specialties.
Some of what you bring up in your article is really more even general advice for you. You have this whole box about pearls of caring for transmasculine patients, for example, and contraceptive counseling and discussion about abnormal uterine bleeding. If you had, one or two just top of the, creme de la creme tips that you think every physician should know as they approach the care of gender diverse populations, what would you say those things are?
I think the first one is just knowing who your patient is. I think we become uncomfortable asking questions, not understanding that patients are okay with us being curious. It's just how our questions are being asked, right? So understanding, we call it the organ inventory, knowing what organs a individual may or may not have. We do this for cis patients all of the time, right? If we're assessing for cervical cancer risk, we want to know if a woman or cis woman has had a hysterectomy and what her pap smear history was leading up to that hysterectomy. It's no different asking a transmasculine individual, have you had a hysterectomy? What was it for? Was it as part of your gender transition, or was it done for something related to either abnormal uterine bleeding or pain? And then what was your pap smear history preceding that? There's no difference. So I think allowing ourselves to be curious and in an affirming and compassionate way, and creating space for our patients to tell us who they are and what they've been through, so that we can then do like risk stratification. So I think that's first and foremost, just knowing who your patient is. It's funny how people can sort of pull back a little and then just not ask enough questions. And that mostly actually comes from good intention. It's because people are afraid to be offensive. They're afraid of their own implicit biases, right? They may actually be more aware of them and be so afraid that they might make somebody feel uncomfortable, when in fact that will make somebody feel uncomfortable if it's clear that they're not asking the same questions they would a cis counterpart. And then I think it's just understanding like nuance, right? I think understanding that you have to extrapolate from what we know from cis patients. You have to put things together. I understand that this individual is transgender. So what are the risk factors for a cis counterpart, right? So a biologic man versus a trans masculine man or a transgender woman. What's the sort of counterpart risk? What surgeries have they or have they not had? What hormones are they on, which would also further risk stratify them, and then sort of put those pieces together. As it turns out, our care, especially in OBGYN, is limited to breast cancer screening, cervical cancer screening, right, and other pelvic organ cancer screening. So there's not a whole lot of puzzle pieces to put together, but there just needs to be a willingness to do that.
Thank you. Another question that comes up as you are discussing these different aspects of care of trans patients is, with the legal landscape changing the way it has across our country, do you have any specific advice for those that are practicing medicine in a state where there are new restrictions regarding the care of trans patients?
It's a great question. I mean, it feels disheartening because we've come so far, and it's actually exactly 10 years from the time that the Obama administration put health mandates through the Department of Health and Human Services about the need to care for LGBTQ plus patients, including transgender individuals. We've had so much improvement in access to care from that time. And then now we're sort of seeing all of these legislative changes that you're referring to. And so it feels like we made such great strides and we're moving backwards. I think that we remaining accessible and knowing what your scope of practice can be, so that you stay within the purview of what you're allowed to do, right? You're no good to anybody if you can't practice medicine, right? So staying within the boundaries, but it doesn't mean that you close your door. In fact, you open your door wider, so that there is better access and you start doing the things that you can do. Patients still need routine preventative health care. They still need gynecologic care. So while gender affirming specific care is now being threatened significantly in a certain number of states, the regular care that we're all really good at and that we know how to do is still necessary. So I always say the door, instead of sort of allowing it to close, just swing it wide open and provide patients with safe spaces to be able to come and at least get the bare minimum care that they need.
I really appreciate that perspective, especially somebody who myself practicing in Florida, something that we do come up against all the time. One last question for you is, as we're hoping to reach the potential authors out there that might submit to the Green Journal, what do you think are some of the process of being studied in the world of trans care?
I only caught a little part of that question. Do you mind repeating it a little bit for me?
Oh, sure. If you could maybe give some suggestions for like researchers out there who might be submitting work to the Green Journal, what do you think are some topics that need additional information in the world of trans care?
So we are starting to study and we're understanding the microbiome of our patient populations more and more. Vaginal health in trans women is an emerging topic. What often happens to our patients is that they have surgery and then they don't get a lot of follow-up care. They don't know where to go. They're in limbo. They don't go back to their primary care doctors. Those individuals aren't as trained, usually, some of them in gynecologic care, or they're even less comfortable with trans feminine post-surgical care. Patients don't always know which OBGYNs to go to. And so there's actually a lot of vaginal health issues that sort of present themselves in more acute like in acuity rather than actual maintenance. And so better understanding that and understanding what happens. These patients have grafted neovaginal canals. They're not the same as natal females. However, interestingly, they run into the same problems as natal females. They just need to be approached a little differently. We're continuing to innovate our surgeries, certainly in transmasculine reconstructive surgery. So the creation of the phallus, the procedure continues to evolve in the management of its complications. So I think there's a lot of room in innovation just within surgery. And then the biggest thing that needs to be done, it's not an innovation, but it's just, we need to do it, is aggregate data. There's not enough aggregate data to really study our patients long-term. We've started to do this, but we need to really understand the long-term effects of both gender-affirming surgery and medical care in things, and how does it affect bone health? How does it affect cardiovascular health over time? All of these things. We know that gender-affirming care improves patients' sense of self, quality of life, their ability to sort of just function in society as whole people. We know that it lowers the suicide rate, especially in adolescent patients and young people. But what we need to better understand is what are the long-term outcomes so that we know how to provide adjunctive care to individuals as they basically go into adulthood, so that we can counter any long-term effects of hormones. You see, everybody is afraid that if we study long-term outcomes and there are concerns about them, that we're going to revoke our ability to actually care for patients early on. But that's not really the point. The point is, how do we ensure that we know what else we should be doing for patients, right? So that we know that they remain healthy throughout their lifespan. So we haven't really sort of studied lifespan care for trans patients. And I think that that's, while not an innovation, a really important part of the future.
Thank you so much for your insights and your expertise. I really enjoyed reading your article. It was so comprehensive and gave such a wonderful overview about the care of gender diverse patients. And I appreciate you taking the time to speak to us today.
Well, thanks for having me. It's a pleasure to be here.
Have a great day.